Thank you, dear friend. To my turn, I want to congratulate the organizing committee for this excellent meeting and for the invitation. In fact, when the Moroccan Society of Cardiology called me and asked me to prepare this talk, it was not an easy job because the literature is really rich and they need really to do a big effort to summarize it and to share with you our experience. As it is an African session, rheumatic heart disease is still a big burden in Africa. And more than this, we are facing a challenge in terms of new epidemiology with the age is more and more old with degenerative disease and increasing ischemic heart disease. The left ventricular dysfunction is classically associated with poor or worse prognosis, but it appears generally later compared to the LV damage. So we have the LV damage, then the LV dysfunction. The consequences of the valve disease on the myocardium is known through the volume and pressure overload, but it's not the only It's not the only actor. There is other actors here, like coronary artery disease, diabetes, amyloidosis, genetic abnormalities, and others. So this, beside valve disease, will damage the myocardium, and you will see here the myocardial alteration, like increased wall tension, chamber remodeling, subendocardial ischemia, reactive fibrosis, and extracellular matrix. So to address the problem of valve disease with the LV dysfunction, in fact, is become to answer many questions. How to evaluate the LV function? Is the routine transthoracic echocardiography enough? Because the majority and the guidelines are based on the transthoracic echocardiography. If it's enough, then how to investigate early LV dysfunction? If we want to ameliorate the prognosis, then we need to diagnose early. Then is the LV dysfunction alone should contraindicate surgery? Then can patient with valve heart disease and severe LV dysfunction benefit from valve intervention? We'll see if we are going to surrender or not at the end of the presentation. This is the outline. I will start by risk scoring. You know all the European score, ST score, and the limitation. There is less accuracy there are less accuracy in high-risk patients. It's not validated for tricuspid valve surgery, and do not include frailty and anatomical factor. And it's not suitable for risk prediction for transcatheter procedure. There is other scoring. The Euroscore, for example, as you know, there is many other parameters more than LV function. And when you click on the LV function, you have good, moderate, poor, or very poor. For the STS score, many other parameters. When you click on the ejection fraction, you need to enter a number, a percentage. You see, between scores, there is some discrepancies. If, in this slide, if you analyze the frailty scores existing now, you can see that, for example, this frail patient here increased the risk of mortality by 1.5, and patient on 4-wheelchair, you see that the risk is really high. So frailty risk or scores are not taken in consideration. We're talking about a patient with LV dysfunction. So what about the evaluation of the LV function? Generally is by transthoracic echocardiography, and in general, the normal LV function is more than 55%. But when we analyze here the recommendation of the guidelines of European, Americans, other societies of the echocardiography, we are confused, and there is some confusion with variation between international societies. You can see here on the green, for example, normal LV function, sometimes more than 55, sometimes between 52 and 72, sometimes more than 50. So there is some discrepancies, and these really make things difficult. So this is why there is new tools like the LV global longitudinal strain, and it measures the LV myocardial shortening. It's more sensitive than in evaluation of LV function. And in a meta-analysis of more than 1,000 patients, asymptomatic severe significant aortic stenosis, almost 15% of patients had some abnormality or have LV myocardial shortening, and this is increase the mortality by 2.5 folds. And these are consistent with patient with normal LV function. Look, we have normal LV function by transthoracic echo. Bypass the new tool here, by LV longitudinal strain, we have patients with bad LV, we will have more and higher mortality. So surgeon should know this is very important in the analysis. The same finding were found here with the group of mitral stenosis, and this paper with young patients, 48, severe mitral stenosis with LV function, more than 50% with rheumatic heart disease. We found that there was subclinical systolic dysfunction as calculated by global longitudinal strain in 16.3% of the patients, which means normally, as we know, the LV function, the LV is protected in mitral stenosis, but with this new tool, we found that the LV was not, in 16% of patients, is not good. This is maybe inferring that rheumatic fever left its impact on the myocardium with some fibrosis, which will continue impairing LV function even after mitral valve surgery. More tools is the MRI, and now we can study myocardium and detect the fibrosis with MRI. And this multicentric study about almost 700 patients with severe stenosis with normal LV function, they found that there was a late gadolinium enhancement in this patient with normal LV function, and in 1% increase in myocardial in 1% increase in LV myocardial scar increased the risk of all cause of mortality by 11% and cardiovascular by 8%. So again here, by echo, the LV function is good. By MRI, there is some concerns. So this is why there is an ongoing trial about asymptomatic patient with severe aortic stenosis. If we can propose an early valve replacement guided by biomarkers, by the gadolinium late enhancement. And the goal of the study is early EVR will improve outcomes compared to the current standard of care in asymptomatic patient with severe aortic stenosis in mid-wall late gadolinium enhancement. And this will answer this question. So what about the management of valvular disease with LV dysfunction? And as it was said, there is many cases, kind of single valve, double valve, or multiple valve. We'll see what's about the literature here. I will not talk, this is the only slide on the guidelines, that to say that the LV function is used in the guidelines as a threshold for surgery indications, and there is no specific mention about the management of valvular disease with LV dysfunction in the guidelines, although the situation is frequent in practice, and there is no guidelines on the management of advanced valvular disease. This is why we go back to the literature. Important paper about mitral valve surgery. Should we withhold mitral valve surgery if the ejection fraction is less than 30%? So retrospective, two groups of patients, mitral valve repair and replacement, and the two groups is group less than 30% ejection fraction and more than 30%. Overall mortality was 14.5%, and by using the analysis, we can see that the factor that predicting mortality in this series is the age, Euro score, high pro-BNP, high pulmonary arterial pressure, more concomitant tricuspid repair, prevalent coronary artery disease, and chronic kidney disease. And there is no citation about the ejection fraction as independent factor. When we go to the propensity matching score, we take 112 patients with LV dysfunction less than 30 and triple more than 30%. And surprisingly, you can see it here, that the mortality is higher in the group with more than 30%. We have higher mortality. There is no significant, it's not significant statistically, but it is fact. More than 30% and the mortality is high. And while the pulmonary artery pressure logistic Euroscore and TAPS have a good predictive value, as expected, the comparison shows that LV ejection fraction diastolic diameters of the left ventricle alone have the lowest and thus a rather poor predictive value surpassed by age alone. So again, a paper is very important, and this is for the mitral valve. This paper is comparing transcatheter mitral valve age-to-age repair versus transapical mitral valve replacement with LV dysfunction. So what is important in this study? This around 100 patients with LV function pre-op of 41 and for the age-to-age repair, and 40 for the transapical valve replacement. The pre-discharge LV function was almost similar. It's important at 3 months, for example, at 3 months here, in the mitral valve replacement group, there is less than 1 plus regurg, while it's just 70 here, and we have more than 10%, more than 3 plus MR in age-to-age repair. We have better remodeling, better LV remodeling at 3 months with the mitral repair group. 1 year cardiovascular-free survival was in favor of age-to-age repair, but it was not statistically different. So mitral valve repair or transapical mitral repair is a good option with patient who needs mitral valve surgery with severe LV dysfunction as compared by age-to-age repair. This paper is comparing mitral clip versus mitral valve surgery in severe mitral regurgitation. It's meta-analysis. It's 9 studies, almost 1,200 patients. Mitral group patient is more older, high previous cardiac surgery, higher rate of coronary disease, higher Euroscore, but there is no other difference between the two groups. What we retain from this paper that long-term mortality is the same, 30 and 35. And of course, bleeding was significant in mitral valve surgery. And the late significant MR in mitral group was noted in this study. A retrospective study about the multiple valve disease, either single valve or double valve disease, and a comparison between 3 groups. Group A is less than 40%. Group B is between 40 and 45% ejection fraction, and Group C more between 45 and 50%. We note that there was a higher pro-BNP and high class in Group A, but it was not statistically different. And for the other parameters studied here, like intensive care stay, like use of inotropic support, and use of intraventricular balloon pump, there was no difference between the two groups. And surprisingly, when we studied the cardiac output, there was no significant cardiac output change in Group A, which is less than 40% ejection fraction, and significant cardiac output decrease in Group B and C with ejection fraction better than Group A. Again, which means that ejection fraction alone was not the good parameter to use. 3 months later, there was some increase in LV function, decrease in the diameter in the 3 groups. This paper is about clinical effects on left ventricular dysfunction in patients with mitral valve stenosis and mitral valve replacement. And the group is retrospective. And this group is important because it's young group. It's like our patients in our daily practice, 25 to 60. and the median follow-up was of 56 months. What we see here is that there was a significant difference between the two groups, and the mortality was high in the group 1 with the lower ejection fraction, comparatively to the group 2 with the better ejection fraction. So patients with LV dysfunction in this series, they do not have no history of hypertension, no risk factor, no coronary disease. So this means that the rheumatic carditis is most likely caused the LV dysfunction in group 1, and this is why the result was the mortality was higher in group 1. The transcatheter and surgical aortic valve replacement patient with the left ventricle function. This is comparative between TAVI and surgical aortic valve replacement. We'll go directly to this point that at 4 years of follow-up, the survival is better for valve surgery than the TAVI, which is an information to need to be kept in our mind. What about the patient with moderate aortic regurgitation, and what is the prognostic impact of the left ventricle ejection fraction in patient with moderate LV, with moderate aortic regurgitation? This prospective study of 1,200 patients showed that the primary endpoint is what all cause of mortality and hospitalization for heart failure. I will move. In this study, if we perform surgery, within the first 6 months after the diagnosis of moderate aortic regurgitation in patient with LV ejection fraction between 35 and 50, you see the difference between, in red, medical treatments, and in blue, the surgical treatment and their impact on hazard ratio, le risque de mortalité. Donc, quand on opère tôt, when we operate early, a moderate ER, we decrease the risk of mortality. What about the tricuspid regurgitation? The tricuspid has its impact on the LV function through ischemia and systolic dysfunction, through the worsening and new onset of the interventricular septum is pushed leftward and compress the LV through the supraventricular arrhythmia and through the systemic consequences. So in this series, patient with a severe or TR with severe LV dysfunction, we notice that the mortality and the new atrial fibrillation and heart failure and the medical treatment management are strongly related to the tricuspid severity. So we have aged patient with TR, more TR is severe, more the patient, even under medical treatment, will have high mortality, high atrial fibrillation, and heart failure. This is why maybe we need to take in consideration this pathology and to start to be aggressive in terms of tricuspid intervention. This paper is from Morocco and is from a military hospital, who showed that the surgery on multiple valve disease with LV dysfunction has acceptable mortality, so it's around 17%, with a good follow-up after the overall mortality after 5 years and survival after 5 years and 10 years, and he's recommending to do multiple valve surgery even when the LV function is not good. 2 slides. We have in our practice 55 patients with LV dysfunction, and we have almost the same parameters. Our mortality is around 9%. And the study is still going on. It is medical thesis. So when to surrender, we need to always to seek for innovation. And why we need to seek for innovation? Because our population in Africa is young, and our goal is to ensure long-term satisfactory results. In our practice, every case is unique, and we need to personalize discussion. Personalized discussion is required. So literature proved that the mortality risk can be improved by to an acceptable level in patients with with valve heart disease and LV damage. How to do that? Because we need heart team, as we said. We need to new management strategy between heart, percutaneous, hybrid. We need to work on our ICU and use of intra-aortic balloon, ECMO, impella, LVAD, and trained workforce. So quickly, hybrid procedures. This patient at 78 years female, normally with coronary disease and valve disease, with a high Euro score, with hybrid procedure. The surgery was done, and the result is good. The impella can be used as well. The LVAD was done in this 55 male patient with congestive heart failure, severe mitral regurg. We did the surgery under preventive LVAD. The LVAD was weaned day 3, and patient did well at 1 year. The LV function was 50 to 55. Beating heart surgery for replacement valve, for aortic valve, for mitral valve, and we have many cases of beating. So, in conclusion, LV dysfunction should not be a contraindication for surgery in valve heart disease. In patients with severe LV dysfunction, multidisciplinary discussion, personalized decision, and special care are needed. Implementing strain study and cardiac MRI in the evaluation of valve heart disease patients is timely to diagnose LV damage before the onset of severe dysfunction. Thank you.